So, Pedro, I started pulling out my database and selected a case from 2012, 2015 for a utterly meaningless conversation, culprit versus complete vessel, really. At the end of it, you have to really decide, are you going to do it next day or next week? So I think the complete trial has clearly... So instead, I just pulled out 2 consecutive cases I did 2 days ago, just before coming here. And I think which actually take the entire conversation out of it, of this multi-staged versus actually doing multi-vessel STEMI. So here is a 57-year-old diabetic, 1 hour of chest pain, and almost always these people present at 1:30 in the night. So no other history needed, nothing at all. Here is his EKG. And I mean, you can have a discussion here what I'm going to find. I don't think there is going to be much doubt. You will have, I mean, there are going to be more than one culprit lesions here. I can't. Looking at the EKG, I can't make out. Is it going to be the LAD or is it the circumflex? Probably both of them. Is the right coronary artery, but any welcome to discuss if you want. But here is the, so this is what I find. There is somewhere around here should be a channel of the LAD. And again, this is also a lesion of the circumflex. And we can go back and look at the EKG. And again, always has been a principle to go after the LAD. That's the one which kills. And not sure it's going to be easy or the channel to find, but...
And just for, if I'm doing this case, I'm thinking about Impella to start, but not maybe, I mean, an EDP, you had an EDP or an LV gram?
Look, exactly right. On the other hand, I have always maintained nothing you need more than quickly open the culprit vessel. I mean, here, young patient having crushing chest pain. So all of this thing is exactly right. So no, I've never ever worried about labs or anything quickly. All you need is a EKG to make a decision. Move the patient onto the cath lab. Again, all that could be done. So here is the first effort. Let's see if the LAD can be wired, and in the meantime, take a quick non-selective picture of the right. So right is not an issue. So I've got 2 culprit lesions, both the LAD and the circuit straightforward. But here is the LAD, which would be more of a challenge. And this is a hydrophilic wire, extra support choice PT, and didn't really require much. It's there in the circle, in the diagonal, moved it quickly down to the LAD, single pass with the export catheter, and this is the result. Proceeded quickly to the circumflex, and that was a piece of cake. Same wire. I often have said that, if ever I'm doing a second lesion, it has to be relatively simple so that you don't prolong it. And one of the things I use is that, look, if it is simple enough, you should be able to use the same wire. So relatively straightforward, but patient presenting with dual culprit lesion, a multi-vessel STEMI. So here it is 24 hours after that. This is at a little more forgiving 11:10 in the evening, and this is a younger patient, 47-year-old, again dual antiplatelet started. This is the EKG, a little easier task than the first one. Yet, in addition to the anterior wall distribution, there is going to be something in the inferior infralateral, mild ST elevation here in V5, V6 also, but clearly there is something happening also in the RCA distribution, probably something a little more subacute, Q waves. Anybody wants to speculate what we are going to find, what to do? I mean, multi-vessel or culprit only?
The pain was like 1-2 hours. Is this
very, very unclear? Which is how I wrote uncertain. I mean, often the classic. When did it start? I've been having it, but even 4 hours before I was not really well, so I cannot pinpoint. Very good question. Looking at his EKG, I can tell you it has been going on for a while. I mean, he already
Yeah,
has
it could
some
be like a
Q
rain-
waves. Yeah.
like a brain infarction or something, recurring angina on a previously
Wonderful.
infarcted territory. Yeah.
Great observation. John?
You have a rightward axis a little bit, right? Does it look like on your EKG,
Yeah.
somewhat of a rightward axis?
Yeah.
Okay. So you have minor ST elevations. Is the troponin positive?
Oh, yes.
Very positive?
Yeah, look, I knew that later.
Okay.
Immediately at that time, he's just presented, moved him on. I didn't have the result right away. But subsequently, we got the results back by the time. Yes, it was.
Okay.
Yeah, it's interesting that the R waves are gone from V1 to V4 and V5
Yeah.
and V6 very small.
I mean, it looks like something right ventricular.
Okay. So let's see what we find. So this is, here you go. There's the occluded LAD and there is a occluded circumflex. And at this moment, I would normally stop here, take a picture of the right, but I'm pretty sure at this point that there should be something in the right also. Not really that sure, but so here you go once again with the same principle. Try to open the LAD first. So this is again a hydrophilic wire and opened up very easily, and that I think is a 3-5 stent. Decent result in the.
Nice
And now
flow.
this one is sorry. Oops. So the circumflex is the one which is a lot more trickier, and also there is a pretty large OMB which you kind of see. It's kind of following this track. You'll see it in one of the views. Looks a pretty, there you go, kind of have a feeling, but keeps tracking into one of these smaller vessels. Tried to use a parallel wire technique, thinking you can get it somewhere here. There is this occluded vessel which should be recanalizing somewhere here. And around this time, you start having this feeling, look, and this to me is the real purpose and the beauty of discussing this case. I mean, here is a patient comes with the anterior wall MI. You open that, everything is looking good. Now I'm chasing this, but let's see. I mean, there is also a EKG, some suggestion this may be another important lesion, but exactly the observation which Dr. Moreno made, there was suggestion that this is something subacute or even chronic. So continue trying. You have a sense there is a place to place the wire, but finally, eventually, I gave it up. Now went ahead and dilated this. Not sure how much this would really have helped. It's a relatively small vessel, and but this is the final result. I have opened this, but clearly this is something the OMB which will require, and of course was somewhat surprised. The RCA is just fine, and took a short hand injection of about 7 cc's. The LV function, of course, he's taken a hit all over. And so how exactly did these two patients did? So here is their follow-up. Both patients discharged home prior to my coming here for this meeting. Both of them did fine. Door to balloon time for the first relatively easy one was 41 minutes for the LAD lesion only, and the second one a little longer. Thank you so much. Happy to take questions.
Fantastic cases, Dr. Mehta. Thank you so much.